I'd like to follow previous presenters with an acknowledgement that we're here on Yorta Yorta country. I'd like to acknowledge the sovereignty of Yorta Yorta people and pay respect to their elders, past, present and emerging. And I'd also like to acknowledge any First Nations people that are here listening or maybe in the future. Every year I show my students, hang on, let's catch up. Every year I show my students a film about Yorta Yorta and Wiradjuri woman Auntie Dr Naomi Mayers, OAM, who was born at Arambi Mission but grew up partly here in Shepparton, part of the extended Briggs family, which more recently includes rapper Adam Briggs. In 1971, as a nurse, Auntie Dr Naomi Mayers was involved in the foundation of the Aboriginal Medical Service in Redfern. She led the service for 40 years until her retirement in 2017. Auntie Dr Naomi was given a Lifetime Achievement Award in NAIDOT Week in 2023. So I pay tribute to Auntie Naomi and encourage my students to learn about her, and also to all the First Nations leadership and creativity that's been nurtured here in Shepparton. So I'm delighted to be in Shepparton. I'd like to acknowledge, as Anne-Marie mentioned, that I'm from Kaurna country, which otherwise known as the Adelaide Plains, and acknowledge the sovereignty of Kaurna people. I'd also like to, I'm going to have a technological challenge because I'm going to read my paper and I've got 3 different things to be doing, but I'd also like to acknowledge my abortion activist and research colleagues, including Erica Miller and most recently Anna Noonan, who are here today. This photo is from the flash mob dance that was performed in Adelaide in 2013. They were also done in Sydney and Melbourne, actually. The event was the precursor to the formation of the South Australian Abortion Action Coalition, or SARC, which has been going strong for nearly 10 years. And my thinking about abortion over that time has been deepened by being part of that group, as well as by more traditional research efforts. So that's me with my SARC co-convener, Bridget Coombe AM, and also my very good friend and fellow feminist historian, Catherine Kevin. So today I'm going to talk about 3 aspects of the current environment in which we seek to provide and improve abortion services. And it's not specifically rural, but I'm sure rural will find its place. The talk is kind of the good, the bad and the challenging. So the 3 aspects overlap, but they don't necessarily directly speak to each other. I begin with the rise of the far-right anti-abortion politics in Australia, the uncertain in my title, then go to the challenges to our thinking and provision of care, and my focus here is on disability. And finally, some celebration of expansion and reassurance that the Australian public is with us. So, and I'm going to read, so as I said, I'm going to be juggling. So first, to these uncertain times. As I'm sure we're all aware, between 2002 and 2023, a national trend unfolded and all 8 jurisdictions in Australia decriminalised abortion. Developments in abortion politics in the latter months of 2024 thus came as something as a surprise to some. In September 24, a Liberal Party member of the South Australian Legislative Council moved a bill to require that people seeking abortions from 28 weeks of pregnancy onwards would be offered the option of a premature live delivery to then give up the child for adoption. The bill, dubbed the Forced Birth Bill, was defeated by 10 votes to 9, a much closer margin in the Council than the vote in 2021 to decriminalise abortion. This reflected the presence of 4 new, arguably far-right members of the Council since the 2022 state election, 3 new Liberals and a One Nation representative. This increase of anti-abortion voters reflected voters in the Council reflected in turn the growing influence of the far right in the state's Liberal Party. And I think this is something that's been happening in Victoria as well. While the bill referred to people pregnant more than 27 weeks and 6 days, arguments in support of it conflated these with all so-called late abortions. Joanna Howe, a University of Adelaide law professor with expertise in labour and migration law and social media influencer who claims a large following, advised the parliamentarian who presented the bill and spoke at rallies to support it. She also pushed out social media content, much of it inflammatory and you might say hysterical. A fortnight after the vote, Howe was banned from areas surrounding the Legislative Council in Parliament House on account of her intimidating and bullying behaviour in relation to politicians on the night of the debate. While the South Australian episode was going on, in the lead up to the Queensland state election, the leader of the small conservative Katter's Australian Party announced that he would seek to remove the 2018 Act which decriminalised abortion in Queensland. Earlier in 2024, Robbie Katter had mimicked federal legislative strategies and introduced a Born Alive bill to provide that the highly exaggerated, if not completely fabricated number of babies born alive following an abortion would be given all the medical care that would be given following any premature delivery. The Katter bill was unsuccessful, but had enjoyed the strong support of Joanna Howe, who testified at the inquiry into the bill and promoted the bill on her YouTube channel. In the 2018 debate on decriminalisation in Queensland, all but 3 members of the LNP, including then Senior Shadow Minister David Crisafulli, had voted against the bill. So the Katter proposal during the 2024 election campaign raised justifiable concern. Soon-to-be Premier Crisafulli said that his party had no plans to change abortion laws, but wouldn't elaborate. Within weeks of being elected, the new LNP government passed a motion to ensure that for the next 4 years, no MP can move to amend the 2018 Termination of Pregnancy Act or express any views on it in the Legislative Assembly. This oddly undemocratic law will keep the lid on any further anti-abortion attempts to change law. ALP leader Stephen Miles described this move as the Premier constraining his own party room because he cannot control them and cannot trust them. The new law will also prevent any reform of the Abortion Act to extend reproductive rights. The new LNP government may have suspended any action on abortion, but it didn't hold back on transgender healthcare. In January this year, they put an immediate pause on new trans patients under the age of 18 from accessing hormone therapies in the state's public health system. And I'll come back to this issue. While argy-bargy about abortion in the Queensland election campaign was going on, Senator Jacinta Nampijinpa-Price, then a shadow minister in the federal coalition opposition, publicly declared her opposition to abortions after 12 weeks and called for national debate. Peter Dutton immediately declared that this would not happen, demanding that party members remain silent on the matter. National Senator Matt Canavan from Queensland agreed that a debate before the federal election would be unhelpful. His Human Rights Children Born Alive Protection Bill, introduced in November 22, co-sponsored with South Australian Liberal Senator Alex Antic and United Australia Party Senator Ralph Babbitt, however, continued to sit on the table, although I think it's probably gone now after the election. Notably, Joanna Howe had both written a submission to and appeared in a public hearing for the Senate inquiry into that bill. In March this year, Howe organised opposition to Greens AMP Amanda Conn's bill to expand access to abortion care in New South Wales. Liberal opposition leader Mark Speakman and Premier Chris Minns both described Howe's spread of misinformation. Speakman condemned her brazen bullying and Americanisation of New South Wales politics. Supporters of the bill, parliamentary supporters of the bill, received online abuse, presumably from Howe's supporters. One MP was led to contact the police. So with Prudence Flowers and Erica Miller, I argue that this intensity of anti-abortion politics in a short period and the advent of a social media influencer as a significant force in Australian anti-abortion politics constitutes the beginning of a far-right counter-offensive to the previous 21 years of uninterrupted Liberal reform. I'm sure I'm not the only one here who was mightily relieved by the Australian electorate's rejection of the politics of the Dutton-led coalition at the recent federal election, but some far-right politicians are unrepentant. In Australia, the far-right has traditionally focused on racism, white supremacy, opposition to immigration, and the promotion of fascism and Nazism. These are all on the rise in Australia, but in the last decade, gender and sexuality have become important new playing fields for the far-right, building, of course, on existing anti-feminist and homophobic movements. Anti-abortion and anti-trans campaigns and legislative proposals are at the forefront of the global far-right movement of anti-feminist and anti-LGBTIQA+ politics, self-described as the anti-gender ideology movement, and Max alluded to this yesterday. Australian far-right actors are solidly connected to the global far-right movement. Social media is a key mode of operation for the far right in the 21st century, enabling its transnational spread and the cross-fertilisation of simply radical with extreme forms. The usual protocols of liberal democracy do not constrain far-right actors, even parliamentarians. In June 2023, in a public hearing as part of the Senate Committee inquiry into the Born Alive Bill, Senator Antic's opening question to a human rights lawyer was, "Is it the position of Australian lawyers for human rights that men can get pregnant?" Despite her simple and direct explanation that while a minority, yes, some men can get pregnant, he continued to ask the same question and feigned confusion. This was transphobia merged with anti-abortion politics. Senator Antic subsequently excerpted his questioning and the lawyer's answers from the Senate video recording of the session and posted it to his own social media. The video was subsequently removed, but not before the lawyer had received a large volume of hate mail, presumably from Antic's online supporters. I have little evidence of how this rise in far-right anti-abortion activity might be impacting directly on the environments in which abortion is being provided, but the challenge for all of us, I think, is to hold strong to our own vision of abortion services, clearly oppose anti-abortion narratives and oppose their far-right tactics, and not be silenced by them, while taking care in the face of their deployment of social media hate speech and possibly litigious tendencies. So none of that means, of course, that we don't stay open to challenges to our assumptions and priorities. I think it's important that intersectional analyses are gaining more prominence in how we think about abortion in Australia, and these analyses, of course, are central to taking reproductive justice seriously. For me, intersectional analyses also involve accountability. In this next section, I'm focusing on the interrelationship of disability and abortion. This is new material for me, and I acknowledge people here today who may be much more experienced than me in navigating these issues, including people with disabilities. I break down this discussion about disability into three sections. The first is the question of access to abortion services for people with disabilities. And I'm guided here by the reports produced by Women with Disabilities Australia. WWDA take an intersectional approach par excellence, calling for the need to address connections between ableism and interlocking systems of structural oppression, including racism, heteropatriarchy, settler colonialism and neoliberalism. WWDA's 2016 statement here on sexual and reproductive rights includes the right to make free and informed choices about their bodies, sexual health, reproductive health, intimate and emotional relationships and parenting, and the right to decide freely and responsibly the number, spacing and timing of their children and to have access to the information and means to do so. The 2022 WWDA submission to the Disability Royal Commission calls for governments in consultation with women with disability and their representative organisations to develop a national strategy to improve access for women and girls with disability to mainstream sexual and reproductive health care. Specific reference to access to abortion care appears, however, it's not a big theme in WWDA's submissions. It does appear, however, in their 2022 report called Towards Reproductive Justice for Young Women, Girls, Feminine Identifying and Non-Binary People with Disabilities. They make the point there that legal rights are meaningless to a young disabled person living in poverty who cannot afford to pay for abortion or is unable to travel to receive appropriate care. Improving access is bread and butter business for people like us who write about, advocate for and provide abortion services. I'm not aware, however, of any research in Australia into the experience of people with disabilities who've sought abortion services, nor of the accessibility of abortion providing clinics. Please tell me if I'm missing some research. Which I might be. The issues that might arise include physical accessibility of spaces, clinical equipment and transport, consideration for Auslan interpreting, sensory-friendly spaces in clinics, information available in easy read format for people with intellectual disability and screen reader friendly websites, understanding of supported decision making, plus staff's training and the presence of people with disabilities on staff. I conducted an informal investigation, not research, an informal investigation of information for people with disabilities on the websites of 5 public and community sector and 5 private sector abortion services, all generally known to offer high quality care. Only the 1800 My Options site, shout out again, only the 1800 My Options site has detailed information, and it says if you have a disability or are advocating on behalf of someone with a disability, 1800 My Options can help you find appropriate sexual and reproductive health care. Other websites had little or no information, mostly none, although the interactive maps to find a service in Queensland, Tasmania and WA and Victoria enable a user to select wheelchair accessible in a search. I admit my website search skills might need improvement, and this lack of information doesn't mean, of course, the service is not accessible, it's just not made clear on websites. And I know there are people here from services who are totally across disability issues. I was talking to some clitorate people yesterday. So abortion comes up in WWDA reports and submissions predominantly in relation to coerced abortion. WWDA repeatedly write of forced sterilisation, forced abortion, forced contraception and menstrual suppression, stating that these constitute egregious forms of reproductive violence against women and girls with disability and are violations of the right to freedom from torture and other cruel, inhuman or degrading treatment or punishment. In the absence of data and research, they call for more investigation into these forms of sexual and reproductive violence. In their submission to the Disability Royal Commission in 2022, WWDA called on Australian governments to prohibit all forms of forced treatment and restrictive practices on and against all people with disability, including forced sterilisation, forced contraception, menstrual suppression and forced and coerced abortion, as a matter of urgency. This is a long-standing call that's been repeatedly ignored. Most recently, WWDA's 2024 preliminary response to the Disability Royal Commission's 2023 report says that they are extremely disappointed that despite discussion of the deprivation of reproductive rights of women and girls with disability, including forced abortion, there are no recommendations regarding these human rights abuses except in relation to involuntary sterilisation. The Senate inquiry's Ending the Postcode Lottery report on sexual and reproductive health care has similarly mentioned coerced abortion in relation to people with disabilities, but made no recommendations to address this issue. It's on this issue that I, at least, feel called to account as an activist, if not as a researcher. WWDA wrote in 2022 of the complicity, and that's my word, of recent activist and policy initiatives regarding abortion, complicity in the exclusion of consideration of sexual and reproductive violence against women and girls with disabilities. They note that abortion decriminalisation focuses exclusively on reforming crimes legislation that criminalises women for accessing abortion, while leaving unreformed the absence of criminalisation of forced and coerced abortion pursuant to disability-specific law. The third section in this discussion of abortion and disability relates to the ableism of some abortion discourse, particularly in relation to later abortions. The area where disability comes up most in abortion discourse is in relation to fetal screening. Erica Miller has noted that in their discussion of fetal screening, the 3 law reform bodies that wrote reports on abortion in the lead up to decriminalisation in Victoria, Queensland and South Australia all constructed disability in negative and purely biological terms. Miller goes on to acknowledge that this assumed negative representation of disability was counterbalanced somewhat by the recommendation, consistent across all reports, that new laws should not include specific grounds for abortion on the basis of fetal anomalies, because such laws have eugenic implications and discriminated against those with a disability. Notwithstanding this recommendation, the South Australian decriminalising law does specify serious fetal anomalies as plausible grounds for performing an abortion after 22 weeks and 6 days. But regardless of law, disability is routinely assumed to be grounds for abortion. Down Syndrome Australia's 2020 submission to the Disability Royal Commission said that once presented with a diagnosis of Down syndrome, quote, families are often pressured to make a decision to terminate even when this goes against their personal beliefs, noting both negative language and a lack of support from medical professionals. Many representations of life with a child with Down syndrome are, quote, at odds with research findings and the experience of most families. Let's also hear from Melbourne-based disability and LGBTIQA+ rights activist, writer, educator and consultant Jackie Brown. Jax is a wheelchair user. Jax and their partner Anne decided to have a baby using partner IVF, where Anne carried Jax's egg in her womb. This is an excerpt from Jax's account of the experience they and Anne had at the information night for prospective parents run by their clinic. So this is Jax. Before attending this session, Anne and I had talked a lot about our capacity to raise a child, including potentially a disabled child. We'd talked about the barriers a disabled child might encounter, as well as supports and services they might need and advocacy work we might have to undertake as their parents to get them access to these things. These conversations forced me to confront my own internalised ableism. I feared the additional prejudice and discrimination that a disabled child might encounter. I knew too well how utterly exhausting it can be. But I also knew that I could teach the child resilience, pride, and the value in being different, as well as connect them to the disability community. So I told the nurse that we didn't want to be tested, that we wouldn't be screening any embryos. I said disability is part of human variation. In response, she leant across the table and grabbed Anne's hand, looked her in the eye and said, "But it's your choice, is that what you want?" It was as though she thought I had inappropriately influenced Anne's decision not to test for disability, and she needed to let Anne know that there was still time to make a different choice. I wondered in that moment what additional pressure the clinic would have applied to us to screen for disabilities had it been my body, my visibly disabled body, carrying our child. There is a fear of disabled people reproducing because we may create disabled children. Disability, like queerness and other non-conforming identities, are seen as not just other but less than by a society that seeks to reproduce the norm. Disabled people, queer and trans people, along with people of colour, have long been discouraged or outright prevented from having children due to fear that we will taint the human race. The experience of disability, it is assumed, should be avoided, and that people with disabilities should feel ashamed of the things that make them different. I am forever grateful, Jax wrote, that in my early 20s I stumbled across the social model of disability, the idea that disability is not all these negative assumptions and stereotypes, but is instead a human rights issue. Now, I don't intend to demean the work of genetic counsellors who work with pregnant people who receive diagnosis of fetal anomaly. I respect their work. I do think that the assumptions and practices described above are a problem. I think it's a problem too when what I'd call mainstream abortion activists and advocates and researchers, like me, for example, and our supporters among MPs and journalists, for example, rely on fetal anomaly diagnoses when called on to defend late abortions. I understand this is tricky territory, partly because of our own ambivalences, perhaps, and partly because anti-abortionists work hard to make late abortions their territory, often appropriating disability rights as part of their opposition to abortion. On the other hand, as we've heard a lot, abortions for people later in pregnancy are the hardest to access, and hospitals often have difficulty providing them for both genuine and spurious reasons. Our turn to often ableist accounts of fetal anomaly diagnoses to explain or defend later abortions also have bearing on how the people who need abortions late in pregnancy are represented. I'm drawing from Erica's analysis here. On the one hand, she writes, there are narratives of later abortions that centre the figure of the disabled child or the non-viable fetus, where the abortion is tragic and the pregnant person can be represented as the sacrificial mother. This palatable representation of the person who has an abortion late comes at the expense of the other 50% of women who have later abortions for so-called psychosocial reasons, who are in turn often represented as impoverished, mentally unwell or drug addicted, for example, marking them as unfit mothers. Both representations displace pregnant people as the subject of reproductive rights. I think we could think of all non-coerced decisions to seek a late abortion, or any abortion actually, as the exercise of reproductive autonomy, with no distinction between psychosocial and fetal anomaly reasons. It's in this context that the need to challenge abortion stigma is most acute. If we aim to normalise abortion as healthcare and avoid universalising accounts of the experience, then we recognise that people make decisions to have an abortion for a range of reasons, and it's no one's business but their own, and they have a range of responses to abortion. But we know that relief is the majority feeling and regret is rare, even when the pregnancy was wanted and other feelings may be involved. There's a great story in 19 Weeks, the award-winning one-woman theatre piece and now film about Adelaide writer Emily Steele's experience of a surgical abortion at 19 weeks. And it was performed in a swimming pool. So you can read this. What do you do the day after an abortion? We go and test drive a car. It's tiny and fun. It's been a long time since I've had fun. We laugh going over the bumps in the road and we say wee going around corners. I realise after I've driven it that I'm still within 24 hours of the anaesthetic and shouldn't be driving at all. This part of the show got a laugh at every performance, the actor who performed Emily tells me. The third and final section of my presentation returns to territory with which I'm familiar, if not entirely up to date, the provision of services and the activism and advocacy of champions behind the progress we are making, as Patty outlined for Victoria so well. In late 2022, or perhaps early 23, when I was finishing my book on abortion services in Australia since 1990, I wrote, "Nurses, midwives and Aboriginal health workers are poised to take over from doctors as providers of EMA, and not only because they're cheaper to employ. Some of the clinics that pioneered the provision of EMA in Australia have been doing so through nurse-led models, and some overseas studies show that women prefer nurse or midwife-led services. And while legislation and or regulation still requires a doctor's oversight, this may change," I wrote, "and nurses may be able to become fully fledged providers, as is the case in some other countries." 2 or 3 years later, it is clear that the nurses and midwives revolution has gone to the next level. Decriminalising law in South Australia clearly stated that not just medical practitioners could lawfully prescribe abortion. I think the legislation in Victoria was not so clearly understood, but also allowed nurses. But it wasn't until July 2023 that the TGA removed its requirement that only doctors could prescribe. In the wake of the TGA, WA included this in their decriminalisation legislation later that year, later 23, and most other jurisdictions have passed catch-up legislation since. Queensland in March 24, the ACT in July 24, in September 24 Victoria announced midwives as well as nurses could prescribe, and most recently New South Wales in March 2025 has reformed their decriminalising law to allow nurses and midwives to prescribe. Of course, there's more regulation to unpack beyond abortion law and the TGA, but the revolution is gathering pace. And just a few examples, which may be familiar. The Cairns Sexual Health Service, who led the provision of medical abortion by doctors nationally back in 2006, have just employed a clinical nurse consultant terminations, a new role funded from the Queensland Women and Girls Health Strategy 2032. Queensland is on track for every community health service to have this position. Nurse practitioners do additional training to be eligible for an extended practice authority to be able to prescribe. There are also changes underway in Queensland, I'm informed, led by the Nursing and Midwifery Accreditation Council to make it easier for registered nurses to be able to prescribe, and this may well include medication abortion. A nurse practitioner in a state I won't reveal provided her first medical abortion via telehealth about 8 weeks ago, having set up her own company to do this. She thinks this might be the first in her state. Telehealth, no scan, one consultation, bulk billed. She was happy for me to tell this story today, but anonymously. She said, "Hopefully once pitchforks and torches are put away, I will gladly fly the flag." And just 2 weeks ago, we saw the launch of Auntie Jane. Quote, "A collective of healthcare providers dedicated to putting abortion care back in your hands. Safe, supportive care in your space on your terms. We're Australia's first nurse practitioner and endorsed midwifery-led teleabortion provider." That's a private service. And in Victoria, as we've heard and I've had chats, a nurse practitioner in a pink trailer known as Nina provides medical abortion to people in regional areas. In a different register, trainee midwives at one of the 2 South Australian University midwifery schools are being sent to placements at the PAC, the Public Abortion Clinic, and the students are loving it. As an antidote to my opening comments about the far right in Australia, I want to finish with a reminder that popular opinion in favour of a woman's right to choose is strong in Australia. Just to remind us. For decades now, 80% of Australians report they support a woman's right to choose. In a South Australian survey conducted in 2019, 63% considered that later abortions should be available when the woman and her healthcare team decide it's necessary. And that's pretty good. I think 63% is pretty good, bearing in mind the misinformation the anti-abortionists put out on late abortions, and that later abortions are much less socially and culturally visible than earlier abortions. The results from the ABC's recent Vote Compass survey, where individuals answer questions to find out where their views line up with major political parties, are also something we can take heart from. Among 436,000 people who responded to the ABC Vote Compass, 66% thought that abortion services should be somewhat more or much more accessible. Among those identifying as female, it was 74%. This shows a remarkable degree of awareness about the problems of accessibility. 92% of people who intended to vote Green, 92%, thought that abortion services should be somewhat more or much more accessible, which to me shows the effect of a party that proactively campaigns on abortion issues. We all know that providing access to abortion services is a big part of ensuring gender equality and reproductive justice. The very disturbing rise of far-right anti-abortion politics may make life harder, and we must pay attention to the meaning of reproductive justice for all, including people with disabilities. But we have a long history of abortion activists and advocates in the community and among providers to draw from, including, of course, many of us here in Shepparton over these last 2 days. Finally, and following Star Lady's comment yesterday, I would commend activism as a way of life that helps us survive the 21st century.